Thank you, everyone. I think we'll go ahead and get started so that we can stay on time. We have a really packed schedule with a lot of really exciting speakers today. Welcome, everyone, to the APA. Happy to kick off the sessions. For those of you who might be newer to APA, the first day of the APA is always we call it a pre-meeting. Obviously, it's part of the main sessions, but the pre-meeting is a focused topic of the APA President's Choice. And so this year, we're very pleased to focus on exocrine and endocrine pancreas interactions, a really, I think, timely topic in the field. I want to thank my co-chair for today's pre-meeting, Dr. Steve Pandal, who helped me with the organizing committee and planning these really excellent sessions today. And we're dedicating this pre-meeting to the memory of Dana Anderson, who was also on our planning committee and obviously was a real giant in the field of pancreatology, but particularly had a deep interest and passion about the interactions between the exocrine and endocrine pancreas. So we thought it was only fitting to dedicate today's session to him. And we'll talk a little bit more about Dana, but I just want to highlight the sessions that we have today. Our goal here was to have a mix of both clinical and basic pancreatology topics and incorporate the pancreatitis and pancreatic cancer aspects, and also a little bit of type 1 and type 2 diabetes and overlap with exocrine disease and those primary diagnoses of diabetes. So I'm going to take just a few minutes before we really kick off the science to remember Dana Anderson and to formally dedicate today's sessions to him. Dr. Dana Anderson was known by many of us in the room as a colleague, a supporter, important scientist in the field. He was a surgeon scientist. He actually had his first research training as a postdoc at NIH on the endocrinology side. So actually started his career, his research academic career in endocrinology. Had multiple academic appointments as a surgeon and surgeon scientist before coming back to the NIH in 2012, where he joined the digestive diseases side of the NIDDK branch and worked there from 2012 to this summer, 2025, at the time of his unexpected passing. He was a past awardee from the APA. He was a recipient of the Service Award in 2018, and many of us know him very well from his role organizing the NIDDK Research Gaps session every summer with Pancreas Fest for many years, and through his passion and support and leadership in the consortiums, the CPDPC, now known as the CPCRC, and also the T1DAPC. He was really instrumental in developing those consortiums, leading those consortiums. It was actually his idea to propose the T1DAPC as a type 1 diabetes funding mechanism using some of the data that was in the field. So he's a really passionate advocate for the study of pancreas exocrine endocrine interactions, and then supported many of us in the field as young investigators. So he's also passionate about developing young scientists and benefiting both patient care, but also improving the research field and the faculty going into this research field. So very quickly on his research, he did start in looking at incretin interactions with insulin secretion, so looking at GLP-1, GIP, back in the 1980s and 90s, and that was his original endocrine focus. But then also developed this field of study in the role of pancreatic polypeptide in particular in patients who had chronic pancreatitis, showing abnormal glucose metabolism with hepatic insulin resistance and a potential connection to pancreatic polypeptide in the sense that when pancreatic polypeptide is administered, some of that hepatic insulin resistance was reversed, seemed to be reversed by infusion of pancreatic polypeptide, both in mice and men, and connected this to a deficiency of the GLUT2 at the liver, causing that insulin resistance. And so this work was done when he was an academic scientist, practicing with his own research, but then he brought that, of course, to the integrated multi-center clinical and translational research happening in the field through the CPDPC/CPCRC and the T1DAPC, this work goes on today. And so he has a real legacy in the field through everything that we're learning about pancreatogenic diabetes, primarily in pancreatitis, but also in pancreatic cancer, through these really important multi-center studies, and has also allowed us to make many collaborations and connections through the field. So with that, I just want to say that we thank Dana for his efforts in this field. We remember him very dearly, and I'm sure he would have really enjoyed today's sessions. So with that, I will turn it over to our moderators for the first session of the day, which is diabetes and benign exocrine pancreas disease. And I think with the last speaker in this session, we'll even emerge over a little bit into the cancer. So Maisam Diraj, I will invite you up to the stage.
Good morning.
Microphone on? Can you turn on the microphones?
Good morning, everyone, and welcome to the first session for the pre-meeting symposium, which is focusing on diabetes and benign exocrine pancreas disease. I'm Dhiraj Yadav from the University of Pittsburgh, and I have Dr. Maisam Abu Al-Haija from the University of Cincinnati. I'll introduce the first speaker for the morning, who's Dr. Katie Larson-Ode from the University of Iowa. She's a professor of endocrinology and diabetes and has specific interest in cystic fibrosis-related diabetes. She's an important contributor to diabetes studies in the INSPIRE consortium, as well as other ongoing work on diabetes in the CPDPC consortium.
Well, that was a really nice introduction. So I'm super excited to talk to you guys today, and I'm grateful for two things. First of all, I get to talk about my favorite thing in the whole world, which is CFRD. And secondly, I get to go first, so I get to listen to the rest of these talks, which I'm so excited about. And I won't be so nervous. So anyway, let's talk about CFRD. Whoops, that was not what I was supposed to do. All right, cool. So just because I assume not everybody here spends all their time thinking about cystic fibrosis like I do, just wanted to refresh you quick. So cystic fibrosis is autosomal recessive. It's caused by mutation in this protein, CFTR, cystic fibrosis transmembrane conductance regulator. And it's a transmembrane ion channel. And the issues with this disorder are you're not getting your anion transport. You get viscous secretions, recurrent infection, all kinds of inflammation, lots of other problems. People with this disorder typically will pass away from respiratory failure. There's a nice little picture of the protein. So, of course, I care about the pancreas and not the lungs. So pancreas pathology and cystic fibrosis, if you have classic cystic fibrosis, begins in utero, and you have fulminant exocrine failure in infancy and toddlerhood. And the thing we often forget in cystic fibrosis, because we're so focused on the lungs these days, is that pancreatic enzyme replacement is life-saving. This disorder was fatal in infancy and early childhood from the exocrine pancreatic failure until we had PERT. And once we had PERT, that's when it became a lung disease. So the pathology of the exocrine pancreas is extensive fibrosis, fatty replacement, and the islets are, quote unquote, relatively spared, which is what everything says if you read it from the older work. Of course, though, otherwise I wouldn't have a job. People with CF get very high rates of diabetes. Depending on where you look, it's 12 to 20% of teenagers, and about half of adults who have classic CF are expected to develop cystic fibrosis-related diabetes. Here's a nice picture from the original description of cystic fibrosis of the pancreas, so you can see the lovely pancreatic pathology. So, I spent at least 5 years of my life, but probably longer, really thinking that we were going to find CFTR itself in the islet, so in the endocrine pancreas and not just in the exocrine pancreas. The exocrine pancreas, of course, is incredibly dependent on the function of cystic fibrosis. transmembrane conductance regulator. So people have reported finding CFTR in the islet, specifically in rat islets and a couple of, my slides are down here. Oh, look at that. In rat islets and also in a couple of cell lines that are used to study beta cells, although they are from tumor cell lines, so they're not exactly physiologic. However, this has not been able to be replicated in other animal models or in human pancreas tissue that wasn't from cell lines. So there's actually a whole bunch of studies on this. Yaling Yi, who is in the audience, has done a bunch of work on this back in the day. And basically the most definitive work was there was single cell RNA-seq done on human pancreas samples. And what they found was there were a few cells that might be beta cells that have some CFTR protein, but less than 5% of what might be beta cells had some CFTR. So the takeaway from that, is that diabetes in people with cystic fibrosis is not because CFTR is broken in the beta cell, and by the way, it's not in the alpha cell either. There's a lot of people got excited. Well, maybe it's in the alpha cell. It's not in an endocrine cell in the islet. I believe this. This is controversial, so you may find other CF endocrinologists who will tell you that I'm full of garbage, but I trust the work done by this group. I trust Yaling. I keep embarrassing her. And I really think, based on my review of literature, what I know about the data, this is not the reason why people with CF get diabetes. So the only reason we really have any good data in cystic fibrosis-related diabetes is because of the advent of novel animal models. So mice and rats are not good models for cystic fibrosis, diabetes. They don't get spontaneous hyperglycemia. But fortunately, I work at the University of Iowa, which is where the CF pig and the CF ferret were developed. And the CF ferret turns out to be a fantastic model for diabetes in CF. They also get lung disease too, which is useful because it actually recapitulates human disease really well. So this is a lovely SIB pair of CF ferrets. They're knockout ferrets. We have other gene mutations too, but this is knockout ferrets. And what you're seeing here is the red dots are a ferret who has both of the CFTR knocked out, and the blue dots are a SIB who's a het. So this is not a normal wild-type white-tail, it's a SIB, a het SIB ferret. And what you're seeing is they're getting their blood sugars checked before and after they eat. And the nice thing about this is that cystic fibrosis-related diabetes, you get glucose intolerance long before you get fasting hyperglycemia, so this is a really, recapitulates it really nicely. So what we noticed in these ferrets is that they're born and with normal blood sugars, and then they have this period where their blood sugars get really, really high, and then it gets better, and then it slowly progresses. So a huge chunk of my life's work was proving that this happens in humans with CF, but we're going to skip that part. The part that I'm excited about for today's talk is that this really, really matches what's happening in the exocrine pancreas. So CF ferrets have relatively normal-looking exocrine pancreas at birth, but between birth and 30-ish days of life, they have rapidly progressive pancreatitis. They develop a lot of fibrosis. There's a ton of inflammation. And what you can see is it matches really nicely. You have this huge derangement in the blood sugars, but then there's recovery. And so that is really, I think, the key to where diabetes is starting in cystic fibrosis. So there's a lot of inflammation, there's a lot of negative remodeling that's happening, and I think the interaction between this negative remodeling and inflammation that's happening in the exocrine pancreas is having really serious and long-term effects on the endocrine pancreas. We know that from this inflammation remodeling, the vascularity is abnormal. That's from Rebecca Hull's group. And the thing about that is here I'm going to hit the animal model side again. So we used to think that islets had unique blood flow that was separate from the exocrine pancreas. And this comes from mice and rat models where the capillary bed for the islet looks a lot like what you see in a glomerulus, where the blood flow goes into the beta cell, then to the rest of the islet, and then to the exocrine pancreas. That's not true in humans. Humans, the blood flow into the exocrine pancreas is completely dependent and interdependent with the exocrine pancreas. The other thing, whoops, I didn't do this in the order I'm talking about it. So I'm going to pop this up. So the exocrine and endocrine pancreases are interdependent in humans, and what you see is things that are secreted by the exocrine pancreas go to the endocrine pancreas, and then of course the hormones that we're used to from the endocrine pancreas go to the exocrine pancreas back and forth via these capillaries. So this is really important. And I think this tells us a lot of things that we don't think about very much, but are really important for pathophysiology in the interaction between the exocrine and endocrine pancreas. The other thing that's important is that the endocrine pancreas has resident macrophages like most other tissues do. And these resident macrophages are essential for islet recovery after pancreatitis, right? And I'm seeing nodding from smart people, so good, I'm not making this up. So, so without these appropriately functioning immune cells, we can't get that recovery that you see in the ferrets, which I think is happening in people, but of course this is way harder to do in little human people. And so you need this function of the immune system. And the thing is that active macrophages use CFTR, so we know that macrophages are dysfunctional in cystic fibrosis. And there's evidence that these macrophages are missing. So part of the incredibly high rate of diabetes and CF may be because we are getting immune cell dysfunction that is CFTR dependent. Okay, so I just yelled at you about how the endocrine and exocrine pancreas talk to each other via hormones. I'm an endocrinologist, so I love hormones. So, local hormones are paracrine, right, instead of endocrine. So it turns out that we have really nice data from the ferret model, too, that there are paracrine hormones that affect the function of the beta cells directly, both in ferret islets and in human islets. And these are islets without CFTR mutation. What was done by some people in the audience here was knockdown of normal human islets and ferret islets who are wild type. And what you can see if you knock down the CFTR is that you lose your glucose-stimulated insulin secretion. So the basal is normal, but the ability to respond to glucose is abnormal, which is exactly what you see in the phenotype of people who have cystic fibrosis and have diabetes. And I would posit, at least based on the continuous glucose monitoring studies we see in people who have pancreatogenic diabetes or post-pancreatitis diabetes, that this phenotype of primarily glucose intolerance, worse than fasting intolerance, may be relevant in other forms of exocrine pancreas disease as well. So this is really cool. So that implies that the exocrine pancreas function directly protects, supports, and drives appropriate endocrine pancreas function. So I was asked to talk about management. We don't have great specific management for cystic fibrosis-related diabetes, but the one thing we have in CF is highly effective CFTR modulator therapy. And it cannot be overstated how important this is for people with CF and the care of people with CF. So these medications are small molecules, and basically they fix the broken protein. And they do it a bunch of different ways, and depending on what's wrong with your protein, you need different combinations of these molecules. I'm going to bring up two of them specifically. First of all, we have ivacaftor, which forces the broken channel to open and let the anions through. So if you have a channel that goes to the membrane but won't open, you can fix it with ivacaftor. And then with our bigger deal one, you fix the protein misfolding, shove it in the membrane, and then force it open, which is a combination of medications. And this picture is a stylized drawing of the CFTR with the binding of the molecules to the inside part of the molecule, which is what causes it to happen. So, whoops, I went the wrong way again. Okay, whoops, sorry, there we go. So the important thing about ETI, ivacaftor alone only treated 9% of people with cystic fibrosis, but ETI, which is the combination drug of 3 of those special molecules, helps over 90% of people with cystic fibrosis to have a near cure of their membrane dysfunction. problem is this medication is horrifically expensive. So it used to be $200,000 a year. I found out 2 weeks ago at the NICFC it's more. I don't know how much. $4,000 or $5,000 a year for therapy? 100,000? 100,000, sorry. What? No, they went up. It just went up because they matched the price of ETI to the new one, Alyftrek. So now they made Alyftrek is more expensive, and they didn't want people to get denied Alyftrek, so they raised the price of the other medication instead. Because there's a brand new one that just came out. Yeah. No, I just found this out at NICFC. It's terrible. Anyway, whoops, I keep pushing the wrong button. Okay, so what happens if we give the ferrets these medications? Because, you can do stuff to ferrets you can't do to people. So the Engelhardt team made ferrets that have this G551D mutation, which means that they are cured by ivacaftor alone, which is a little bit easier from a model perspective because it's a little bit cheaper than the combination drugs. And so if you have ferrets that are G551D homozygous, and you start them on ivacaftor like during pregnancy, they are born with completely normal pancreases, and they won't have any pancreatic insufficiency, and they do not develop abnormal blood sugars. However, if you have a ferret who has the treatable mutation on one side and a knockout, and we still don't have any treatment for knockout, and there are humans who have the equivalent of knockouts. On the other one, you can see that you get some rescue, but not complete rescue, is basically the story. And here's the part that is more important. And so the one thing that they did that was really smart is they took some of these homozygous ferrets and they took them away from their HEMT. And what happened is they developed rapidly progressive pancreatitis, and then some of them eventually developed glucose instability. Okay, let's talk about what we know about these medications and the human pancreas. So I'm going to separate exocrine and endocrine. We have a little bit better data on exocrine. So ivacaftor alone in people with gating mutations. It was, of course, initially approved for 12 and under, and then 6 and under, and then 12 months, and then 6 months. And I think it's approved now down to 1 month. So we have data we eventually got data of descending. So the thing that I'm showing you here is the top one is the 2 to 5 year. If they started at 2 to 5, and of course this is fecal elastase. And one thing I've learned from you guys is that fecal elastase is not a great measure, but I don't know as we know anything else to measure, so that's what we measured. So what you're seeing is the fecal elastase levels at before they started the medication, and then going up to 2 years post-medication. What you can see is the top bracket is the older kids who were 2 to 5 years when they started, and the bottom bracket is the kids who were 12 to 24 months. And the takeaway is, as ugly as these things are, each line is a kid, that it's better if you start it younger. That's pretty straightforward. I think you can argue about what all else is going on, but I think you can argue pretty safely that the exocrine function improves more if you start younger. Whoops. Goodness gracious, I keep going backwards. So with ETI, we just finally got our data from 2 to 5 years old people, and we presented this, the BEGIN trial presented this at NACFC. So this is hot off the press. This is 2 weeks old from when we presented it. But what you can see in this group of kids who started between 2 and 5 years of age onto ETI is we saw technically there was improvement. There was a statistically significant increase in fecal elastase after treatment. It's not very big. So what Lucas told me is that he kind of feels like this isn't, he can't say that this is clinically significant, but there's a tiny bit improvement. So my takeaway on this is, and we don't have data on kids that are younger, but so it's similar to ivacaftor, but not as good, and that's what we see with a lot of things because the mutations are more severe. So we have case reports of people who were treated in utero, either from a mom with CF who got pregnant and so was on it all the way through, and then we also have had het moms now who have successfully obtained it somehow and taken it. And what we know is if you're exposed from conception, you'll have a normal pancreas. And you will pass your newborn screen because the newborn screen picks up in utero pancreatitis. So your in utero pancreatitis that everybody with classic CF gets won't happen, and your exocrine pancreas will stay normal, assuming you can stay on these meds, which is kind of dramatic. And the new data from the NICFC is that if you start it in mid-pregnancy, it's not nearly as efficacious as if you start it at the beginning of pregnancy. So how about diabetes? So we don't have as good of data. What? I'm overdue? Oh, shoot. So I'm almost done. So basically, it doesn't fix the diabetes nearly as well. So we see a there's been lots and lots of people who've looked at this. There are very small effects. Some people have improvement. Some people, if you test it, people improve a little bit. And it doesn't fix it. That's the short version for now. So my conclusions. Obviously, I'm here. We're going to talk about this. Endocrine-exocrine interaction is like so important. We need better models for exocrine pancreas disease, which I don't think is news to this room. And I think we'll cure diabetes and CF when we cure the exocrine disease. And there's my thank yous.
Thank you, Katie. You can go back. Well, wonderful talk. It's, I think with the timer for the tech team, if we can just set it up at the 15 minutes that we gave the speakers to reset, thank you so much. It would be my pleasure to introduce our next speaker, Dr. Kathleen Dungan. And Kathleen is a professor of medicine in the Division of Endocrinology at The Ohio State University. And she's the interim director of the division and director of the Diabetes Center of Excellence, a lead on actually a multi-center studies and a national figure in the trials of diabetes and therapeutics in diabetes.
Awesome. Thank you for that kind introduction. So I get to talk about prevalence and mechanisms of acute and chronic pancreatitis, and only get to talk a little bit about little bits and pieces, but let's get started. I do have some disclosures, so feel free to peruse those. And first of all, as many of you are already aware, this study of diabetes related to pancreatic disorders is a little bit complicated. Not so much that we don't know how to diagnose either diabetes or pancreatitis, but although that has changed a bit over the years, so older studies could be affected. But it's just reasonably difficult at times to ascertain the causality and temporality related to the two. So this has resulted in a number of previous terminology, some of which has kind of fallen out of favor. But really, the vast majority of these cases are acute pancreatitis, and so that's going to color a lot of my experiences that I've had with T1D APC. So just to give you an example of, how widespread underdiagnosis or underrecognition, if you will, is, this was just an example of a very large primary care records analysis. And on the left panel there, you can see the prevalence of type 2 diabetes. By far is most common, of course. But what's interesting is that pancreatic causes of diabetes is actually more common than type 1 diabetes. And then the other part of this is, why does it really matter? Because isn't there overlapping mechanisms? But we know that people with both acute and chronic pancreatitis are more likely to need insulin, so it colors our treatment decisions. And this is likely, at least in part, related to more difficult to control. And then if you drill down on those individuals who were determined to have pancreatic causes, what was the chart diagnosis originally? Well, the vast majority of these were type 2 diabetes followed by type 1 diabetes. So a lot of under-recognition going on. And again, speaking to the outcomes as to why this might be important, both acute and chronic pancreatitis are associated with severe hypoglycemia. And also some evidence from this study, at least, that there's an increase in risk of mortality. So specifically acute pancreatitis, A number of studies have been done. Many of them, again, like I said, could have been using different criteria for diagnosis of acute pancreatitis and even criteria for identifying diabetes. So with that in mind, within this very large meta-analysis, we're seeing a pooled incidence of 23%, which is higher in those who've had severe acute pancreatitis as opposed to mild cases. Also, alcohol as an etiology was identified as a risk factor, and the mean follow-up here was 5 years. And specifically drilling down on some of the risk factors in particular, which really informs what the mechanisms would be. This was another meta-analysis that actually looked at these risk factor and outcome pairs. And so they identified, again, severity of pancreatitis, the alcohol etiology, and then as a negative risk factor, biliary etiology. But a lot of these other kind of traditional type 2 diabetes risk factors didn't really play out so much, which is really interesting because we've got this mix of maybe obesity was still a risk factor, but we get this mix of both pancreatic risk and underlying type 2 diabetes risk. So then what about chronic pancreatitis? This is a meta-analysis. Again, we have some of the same kind of similar sort of limitations in pooling all of these studies together. But nevertheless, pooled incidence, 30% over the duration over all of these studies with, again, this temporality, of course, with 33% at 5 years. And then minimal effect of some of these other risk factors. And I'll get back to that in a second because it kind of depends on what your population is as well. So further follow-up up to 20 years, we see the incidence increase. And then if you look at cohorts of patients, studies that are enriched in autoimmune pancreatitis, seeing higher prevalences, and then the highest are in more of the hereditary causes, and in which you see up to 80%. So just couldn't show all of those studies. But what's interesting in this recent analysis is this identification of microvascular complications, which was increased. And again, I think that would follow, but it's nice to really know and understand that this is a distinct entity. And then in terms of predictors, pancreatic calcifications were identified as the primary predictor in this study. And then in a larger study, many of you have been involved in the North American Pancreatitis 2 studies. In this multivariate analysis, I just kind of separated out some of the more pancreatitis-related versus maybe type 2 diabetes-related risk factors here. And so you can see a little bit of a mixture. This is a little bit bigger study, so duration of pancreatitis and all kinds of pancreatic sort of features. But now we're seeing family history, obesity, and age, which we know is a risk factor for type 2 diabetes anyway. Okay, so let's talk a little bit more about some of the specific underlying mechanisms. We have, as I mentioned, we have the canonical, underlying type 2 diabetes risk, pancreatitis severity, especially for the acute pancreatitis, that initial event, and any additional events. And perhaps some interest in some maybe genetic determinants. So in acute pancreatitis, we see overall more insulin-resistant type picture. And this is really a spectrum, so I'm artificially separating the two, but really this is just kind of a continuity. There is a degree of beta cell compensation, so increased secretory capacity based upon the underlying reserve. But we also see some beta cell dysfunction, in part due to both the direct localized islet inflammation and also systemic inflammation. What's really kind of interesting is some of this has even been worked out as opposed to the specific inflammatory mediators. And really impacting PDX1, which is a really critical transcription factor in the islets. So systemic inflammation, post-insulin receptor signaling defects play a role. And then what we don't know and what we'll be, maybe teasing out a bit more is how much pancreatic exocrine insufficiency and potentially its implications for incretin function plays a role in acute pancreatitis, perhaps more in chronic pancreatitis, but even that is not well understood. And finally, one of the things we're studying in T1D-APC is autoimmunity. So what about chronic pancreatitis? Now we're talking about really trending more for loss of islet cell mass, both direct injury, but also some apoptosis. This will result in not only insulin deficiency, but alpha cell loss, which will lead to a loss of counter-regulatory responses. And that is underlying this risk of hypoglycemia that I mentioned earlier. And then as Melina mentioned earlier with Dane Anderson's work, one of the most novel features especially with chronic pancreatitis is the loss of pancreatic polypeptide, which is really important for hepatic insulin resistance. So in just kind of putting these all together in acute and chronic pancreatitis, we can see that there's a lot of work left to be done because there's some conflicting data there, and these are things that are being worked out in some of the ongoing studies. And I'll give you a couple more examples here. I thought this one with Mark Goodarzy's work was of interest here. What about, distinct genetic risk scores? And in pancreatitis, at least chronic pancreatitis, it looks very much like type 2 diabetes in terms of the genetic risk scores. And then islet autoimmunity, as we mentioned, is one of the emphasis of the T1D-APC. It's actually so far seems to be only in a minority of patients, and maybe those who have that underlying predisposition, genetic predisposition. It's definitely more common in recurrent or chronic pancreatitis, and in the pediatric cohorts. So more to come on that. But really, the interesting hypothesis is that perhaps this inflammation can generate a loss of self-tolerance in some cases. All right, so finally, I wanted to just mention how does this impact our daily practice here? And so recently, the American Diabetes Association has laid out some recommendations for screening. They recommend screening at 3 to 6 months after the diagnosis of acute pancreatitis and annually for all acute and chronic pancreatitis. They actually rated the evidence as expert opinion grade E, whereas the most recent consensus on guidelines on acute pancreatitis have suggested that level of evidence is moderate and made a more strong recommendation. And that's something that we are looking at as well in T1D-APC. So thank you very much.
Thank you, Kathleen. Our next speaker is Dr. Peter Hegi from University of Pécs in Hungary. Peter has led over the past several years studies spanning experimental pancreatitis to large clinical studies that currently are ongoing in Hungary and have really contributed our learnings within the spectrum of acute through chronic pancreatitis. He was recently awarded a prestigious award in physiology internationally, the Robert M. Pitts Award, and he really is leading a lot of effort in terms of education of trainees from medical students all the way through PhDs. So Peter is going to talk to about global perspectives on diabetes and pancreatitis, updates from the Hungarian study group.
Thank you very much, Gira, for this very nice introduction, and thank you for the organizer, especially to Melanie, for the kind invitation to this conference. So as you know, like acute pancreatitis, plenty of people look at what's happening in pancreatitis or how to prevent pancreatitis. In our recent works, concentrated on the follow-up, what's happening after pancreatitis. Luckily, 97% of the patients survive in acute pancreatitis. But what can happen? Of course, when we discharge the patient can die. And of course, they can have chronic pancreatitis, they can have diabetes, they can have pancreatic cancer. And I am just speaking right now concerning pancreatic diseases. So concerning mortality, we were a little bit shocked at the very beginning, actually, to see that in year one, there is really a high chance to die for these patients, and especially if the first 90 days of the patient are in danger, especially in year one, twice more people die after pancreatitis than during hospitalization. And we also looked at what could be the factors which actually really risk for the patients, and this was among severe pancreatitis of these ones. But of course, they can have chronic pancreatitis as well, and we have recently shown that there is a completely different disease after the second acute pancreatitis, the recurrent pancreatitis, because 3 or more acute pancreatitis, the probability of having chronic pancreatitis is really high. And now we have direct evidence also in animal models that this is already, you can see the pathological changes inside the pancreas. So we call this group an early chronic pancreatitis one. And here is just one example about our recent article, which is not yet out, but already accepted in gastroenterology, showing about the distribution of the pancreatic morphology in the first acute pancreatitis. You can see that around 3/4 of the pancreatic patients has the very first pancreatitis, and the second group, around 10%, has about recurrent. You can see those who has more than 3 acute episodes without any kind of morphological ductal changes, and the red one, which is the chronic pancreatitis. And if we follow these patients year by year, you can see actually on the picture that after 5 years, more than 50% of the patient has either a second attack or early chronic pancreatitis or chronic. If you choose the population which had no preliminary pancreatic diseases, but the first one, after 5 years, 1/3 of the patients, the disease going forward. If you look at those groups where they had 2 episodes of acute pancreatitis, after year 5, more than 50% the recurrent episodes come back and causing at least early chronic pancreatitis. And those group who had early chronic pancreatitis, 1/3 going forward for chronic pancreatitis. So acute pancreatitis is not an acute, it's a chronic disease for the patients for the forthcoming years. And here is a paper showed by our group that really hyperlipidemia and alcohol, so the toxic factors which are actually responsible for the recurrent episode of the pancreatitis. Of course, the patients can have pancreatic cancer as well, and we also showed that those patients who had idiopathic pancreatitis had 3% chance to have pancreatic cancer, and especially those who had pseudocysts inside the lumen. So those patients who has idiopathic pancreatitis and pseudocysts, especially in the first 2 years, they have very high probability to see them to develop pancreatic cancer. But today I would like to speak more about the diabetic part, that these patients is really in danger of developing pancreatic endocrine function changes. I really like reading old papers because there are plenty of information which can come out. So this is a paper from 1927. It's almost 100-year-old. But this was written that in those patients who have died in diabetes, in the pancreatitis group, it was not possible to see always a beta cell loss or beta cell function. So our current knowledge is really what is causing diabetes after pancreatitis is a loss of beta cells. I am not sure. If I look at another paper, a little bit younger one, this was in 1963, and if I look at, it's writing down that recurrent inflammation, so inflammatory processes, most probably like cytokines, can be responsible for what's going on. So we actually followed the patients with acute pancreatitis, and this is the very first, when we diagnosed them, around almost 30% of the patients had either prediabetes or diabetes on admission during acute pancreatitis. And when we followed them for 4 years, you can see that especially at the very beginning, in the first 2 years, actually diabetes was growing and also prediabetes. In those groups who had only the first episode of acute pancreatitis, no inflammation before, still almost 3/4 of the patient had at least abnormal glucose tolerance. Of course, those groups who has already chronic pancreatitis, almost all patients after an acute and chronic pancreatitis, diabetes developing. And here you can see the risk, like the alcohol and especially the lipids as well. So this is a summary figure, and I would like to highlight this. These patients had no pancreatitis before, completely normal hemoglobin A1C, so completely healthy pancreas before the single episode of acute pancreatitis. And still this group, over 50% of the patients after 4 years develop abnormal glucose tolerance, and most of them are prediabetes. And if you look at the episode, this is a progression change, which means at least one level they went from normal to prediabetes or from prediabetes to diabetes. You can see that this happening in the first 2 years. So after acute pancreatitis, something happening in the first 2 years, which is not like beta cell loss, but something which damages the beta cell function. And when we looked at the C-peptide for this group, this is not growing down, this C-peptide. So this is not the loss of the beta cells. There is something different things happening. And if you look at the HOMA index, is also very elevating, showing that this is like something like the type 2 diabetes. And I was very pleased to see from Kathleen's presentation, this article was showed from Olga, that what are the really key factors which elevate the risk for diabetes? Exactly the same factors which actually elevate the risk for recurrent episode. So there must be a direct toxic effect of alcohol, fatty acids, and smoke extracts also on the beta cells, which can either induce recurrent episode or diabetes. We also looked at the dose dependency, and this paper just came out a couple of weeks ago, and it was also shown in the article that also these kind of toxic factors dose dependently stimulate actually and trigger the development of diabetes. So if I look at an inflammatory fibrosis model, this was what we learned from textbooks, that if the disease growing from acute to recurrent, early chronic and chronic, this inflammation will finally kill the islet cells and will cause prediabetes or diabetes. But this new model, which is a toxic model, which means that all toxic factors which actually induce the disease outgoing from acute to chronic pancreatitis, exactly the same factors going from normal diabetic stage to diabetes. So if I look at the conclusion, these patients definitely need closer survivors for mortality, recurrent episode, diabetes, and all the others. They also need to have a follow-up. Due to the high mortality in the early stage, we just says the follow-up after 1 month, 1 year, 2 years, and look at not only the mortality, but also like the glucose status. If you do clinical trials, we strongly suggest to have post-discharge mortality also among the endpoint, and also those studies which were published in the past needs to be evaluated. So it was also shown very well by Catherine about what plenty of questions we still have concerning the inflammation-driven beta cell dysfunction, the severity, how they do the remodeling, toxic factors I just showed you earlier, even dysbiosis, gut barrier function, the microbiome. Albert Nash has brilliant studies on how the microbiome can affect on the development of diabetes and so on. But we already started looking at these patients, what we followed after acute pancreatitis. And I showed you the paper in actually 1963 where they wrote down that the inflammation is completely changing the beta cell function. So we have a huge acute pancreatitic database, over 5,000 patients, and there is a group who needed insulin during the course of diabetes. This group no needed insulin during the diabetes. Here is the N numbers for different days. And what we showed that those groups who received insulin, actually the CRP level was higher. So higher CRP level during pancreatitis is associated actually with the necessity of insulin. And when we followed each day the patients, you can see how the CRP level elevating and decreasing. In every day, those groups who had a higher CRP level, higher inflammation, needed more insulin than in those groups where the inflammation was lower. And this is actually when we looked at an increasing elevation of insulin from one day to the other day. And this is when the insulin level, the light blue is where it didn't came, and the white which was decreasing. In day 3, when we knows that the highest level of the CRP, these 4, the insulin level were continuously elevating. So the insulin necessity, what the patients needed for normal glucose levels. So when the CRP rising, the necessity of insulin is rising. When CRP is decreasing, the necessity of insulin is decreasing. So there are, of course, lots of questions. These figures just came last week, and I just put it to the presentation. But this is what we would like to understand. I am very happy to lead the Hungarian Pancreatic Study Group, which actually has really huge database for pancreatic research. I love the APA. It's always one of the most highlighted conference for me, and I also would like to thank for the whole research group, including the patients and the medical team, to be with us and helping us. Thank you very much for your attention.
Thank you, Peter. Enlightening talk. It's my pleasure to introduce our last but not the least speaker of the session before we open it for Q&A, Dr. Atsushi Masamune. And he is currently the Vice Director in Tohoku University Hospital, Professor and Chairman at the Division of Gastroenterology. And he has many leadership positions that I would like to highlight of, that he's the Director of the Japan Pancreas Society. Very pleased to have you here with us.
Thank you, Professor, for the introduction. Today, I'm fully aware that my talk is assigned to the session of benign pancreatic disease and diabetes. But I'd like to talk both on pancreatitis and pancreatic cancer, because as you know, these diseases are closely related and overlapping sometimes. I have no COI to declare related to this presentation. This is a result of a nationwide epidemiological survey of pancreatic diabetes in Japan in 2005, a little bit old data. According to this survey, pancreatic diabetes accounting for 1.7% of patients with diabetes, and 2 pancreatic diabetes, that is a diabetes developed after pancreatic disease, accounting for 0.8%. Chronic pancreatitis was the leading cause of pancreatic diabetes, accounting for 40% of the cases, followed by pancreatic cancer and pancreatic resection. In the nationwide epidemiological survey of chronic pancreatitis in Japan in 2016, 42.4% of the patients had diabetes. This is our recent data showing the prevalence of the cumulative rate of diabetes in patients with alcohol-unrelated CP. In patients with PRSS1-related pancreatitis, cumulative incident rate of diabetes was 17.4% at 30 years and 51% at 50 years. In the case of a patient who did not have a mutation in the pancreatitis susceptible gene, the prevalence of diabetes was 3.6% at 30 and 22.6% at 50 years old. However, the autoimmune pancreatitis, according to our latest nationwide epidemiological survey in 2021, before the treatment with glucocorticoid, diabetes were developed in about 40% of the cases with autoimmune pancreatitis. After the glucocorticoid treatment, diabetes newly developed in 60.3% patients, and in the case of the patient who had diabetes before the treatment, diabetes was cured in 6%, worsened in 40%, and improved in 24%. Therefore, diabetes is common in patients with chronic pancreatitis and autoimmune pancreatitis in Japan. The slides show the annual trend in cancer mortality by site and sex in Japan. Since the 1950s, gastric cancer was the leading cause of cancer-related mortality in Japan for a long time. However, the number has already decreased, mainly due to the advance in the endoscopic diagnosis and treatment and the eradication of Helicobacter pylori. The number of liver cancer-related deaths also started to decrease, mainly due to the elimination of hepatitis virus. In the case of lung, colon, and pancreatic cancer, the cancer-related mortality still continues to increase in recent years. In the year 2000, mortality due to pancreatic cancer was less than 20,000 and ranked number 5. In the year 2024, pancreatic cancer was ranked at number 3, and more than 40,000 patients died of pancreatic cancer. 5-year net survival for all cancers in Japan is currently 66.2%, but the survival rate is as low as 12.7% in the case of pancreatic cancer. 10-year net survival rate is 6.4% for pancreatic cancer in Japan. This is the algorithm for pancreatic cancer diagnosis proposed in the most recent clinical practice guidelines for pancreatic cancer in Japan, which were revised in August this year. Diagnosis process begins with clinical symptoms, pancreatic enzyme levels, increased tumor markers, risk factors, and abnormal imaging findings of the pancreas. The next step is to perform contrast-enhanced CT, MRI, and/or EUS. Whenever possible, the diagnosis should be confirmed by cytology or histology. After the diagnosis of established, staging diagnosis is required. Therefore, understanding the risk factor for pancreatic cancer is essential for its early diagnosis. There are many risk factors for pancreatic cancer, including family history, genetic disorders, habits, lifestyle-related diseases, including diabetes and pancreatic diseases, and the imaging findings of the pancreas. Among these risk factors, diabetes is associated with a twofold increased risk of pancreatic cancer. When examining the relationship between pancreatic cancer and diabetes, two key aspects should be considered. First, is diabetes itself a risk factor for cancer? Second, does pancreatic cancer lead to new onset diabetes or worsened glycemic control? This is a question like which comes first, the chicken or the egg? A meta-analysis of 88 studies showed that in patients with diabetes for less than 1 year, the risk of pancreatic cancer was as high as 6.69. The duration of the diabetes longer, the risk of pancreatic cancer decreased. In patients who had diabetes for more than 10 years, the risk remained statistically significant after 10 years. Therefore, diabetes may represent a manifestation of pancreatic cancer. So the question is, does focusing on diabetes contribute to early diagnosis of pancreatic cancer? For screening strategy of pancreatic cancer, we adopted so-called DEF approach. That's a three-step strategy using SIPs. The first SIP is to define the at-risk population based on risk factors, including diabetes, and clinical phenotypes. The second SIP is to enrich at-risk cohort using scoring system and biomarkers. The third SIP is to find early lesion based on imaging studies. So to evaluate the utility of diabetes as the first SIP, we should know the current status of pancreatic cancer among patients with diabetes. Therefore, we conducted a nationwide survey targeting diabetologists in Japan. In the first survey, we sent a questionnaire asking for the number of patients with diabetes, and among them, the number of patients diagnosed with pancreatic cancer to 856 educational facilities certified by the Japan Diabetes Society. In the second survey, we collected detailed clinical data for pancreatic cancer. The annual incidence of pancreatic cancer per 1,000 patients with diabetes was 2.0, corresponding to the annual rate of 0.2%. In Japan, annual rate of pancreatic cancer in the general population was 0.056% in age after 40 years and 0.071% in individual aged 50 years or more. So by focusing on diabetes, we could enrich by 3 to 4-fold. Primary diagnostic figure for pancreatic cancer in diabetic patients were the symptoms in all cases, followed by worsening diabetes and incidental detection by imaging studies. However, in early pancreatic cancer cases, incidental detection by imaging studies were leading primary diagnostic figure for pancreatic cancer. Importantly, most cases are detected in asymptomatic patients. The slide shows a stated distribution by diagnostic triggers. In patients diagnosed upon the appearance of symptoms, stage 4 cases account for 50%. However, the proportion is decreased in patients detected incidentally by imaging studies. Similarly, if the patient was diagnosed related to diabetes, stage 4 accounted for about 4 of cases, and stage 0 or 1A cases account for 10%. Therefore, diabetes might lead to earlier diagnosis of pancreatic cancer. However, the second SIP using the scoring system and biomarkers. There are many risk models of pancreatic cancer or scoring system proposed in new onset diabetes. These studies analyzed 110,000 new onset of diabetes cases and identified these 10 factors to calculate the risk of pancreatic cancer within 3 years. in these studies, they analyzed the UK Biobank data and combined the clinical phenotypes and the SNP data. With a cutoff value of 5.26%, 2% of the patient needed further evaluation, and pancreatic cancer was detected within 2 years in nearly 20% of the cases. However, these risk models are a little bit complicated. This is a very well-known ENDBAC score, and Enlisting New Onset Diabetes for Pancreatic Cancer score. This score employs just 3 items: blood glucose category, body weight change, and age at onset. If the total ENDBAC score is more than 3, 3-year pancreatic cancer risk is 3.6%. So these studies show that focusing on diabetes might provide opportunity for the early detection of pancreatic cancer. But it remains unknown whether diabetes is useful for early detection of pancreatic cancer in high-risk individuals. Therefore, we focused on IPMN. We conducted a prospective multi-center surveillance study of 2,104 cases with branch-type IPMN in Japan. The participants undergo regular imaging examination every 6 months for 5 years. Primary endpoints are progression of branch-type IPN, development of high-grade dysplasia or IPMC, and concomitant PDAC. At 5 years, high-grade dysplasia or IPMC developed in 1.91% cases. Larger cyst size, larger MPD size, and mural nodule were associated with the development. In the case of concomitant PDAC, 2.11% of the cases developed at 5 years. Male sex and older age were associated with the development, but the size of IPMN was not significant. Then we analyzed the HbA1c levels in these participants. Interestingly, the basal HbA1c level was higher in patients who consequently developed malignancies. The difference still remained significant during the 5-year follow-up period. Interestingly, in the case of concomitant PDAC, HbA1c increased 6 years before the diagnosis of CPDAC. In the case of IPMC, the increase was not so significant. Anyway, HbA1c might serve as a surrogate marker for CPDAC in blood-type IPMC. So, in conclusion, diabetes frequently developed in patients with chronic pancreatitis and autoimmune pancreatitis also in Japan. Diabetes is an important risk factor for pancreatic cancer and may serve as a surrogate marker for its early detection. Further studies are warranted to establish systemic models for the early diagnosis of pancreatic cancer in patients with diabetes. Thank you for your kind attention.
We would like to invite all the speakers back to the stage for the Q&A session. And while they are coming up, I would open it with a question to Dr. Katie Larson. So Katie, you covered very nicely the cystic fibrosis abnormalities and the importance of the crosstalk of the exocrine and endocrine cells. So if we block that porous membrane between the exocrine and endocrine cells, that insulin secretion does not happen, as we've shown on the pancreas on a chip. Do you have any, please have a seat. I just keep talking. Do you have any speculation on CFTR modulators and correctors for exocrine disease? We know it improves the function. Yeah. Do you know if it would improve the beta cell responses to glycemic input, and would it improve insulin secretion in CFTR abnormal patients?
Okay, let me see if I can parse that. So you're asking me in people who don't have cystic fibrosis if I think correctors would help?
any CFTR abnormality with cystic fibrosis disease, CFR,
Yeah.
RD, yeah.
So, okay.
I don't know if there's any work, so I was
So
hoping you could
there's
tell.
some data in the milder forms of cystic fibrosis. There's probably more benefit. There's also more benefit for the exocrine pancreas. So I really do think it's probably, I mean, if you want my opinion without data, it's that I think the benefit to the endocrine pancreas is from the benefit to the exocrine pancreas. And part of it, I didn't have time to cite your work, but as far as CFTR heterozygotes, we know they get more diabetes. Probably correctors in heterozygotes probably would reduce their risk of diabetes, I think, but I don't know.
We need to study it. Ideas for the fellows in the room. It's a study.
Yeah, please introduce yourself and then ask your question.
Good morning. Hi, I'm a fellow from the University of Miami, Department of Surgery. Great talk to all the panelists. Thank you so much. First question, I'll follow up Dr. Heiser, who asked Dr. Larson. So, great talk, by the way.
Thank you.
So, in your ferret model, right, did the observation you mentioned about the exocrine function protecting and supporting the endocrine function, is that just unilateral, or is it just endocrine can also do that? There are some reports
Are
that
you
do that.
asking me if the endocrine function
Also
can
supports
protect the exocrine function? Yelling, I don't think we didn't look at that at the ferrets, right? It was the other way. We only looked at it the other way around that I know of. Yelling is sitting right there. She actually did most of the ferret work. She's in the blue jacket.
Okay.
Yeah, there is, okay, I'm trying to remember where it's from, but there is data to show that the islets are important for the exocrine pancreas. I don't think we've looked at that directly in the ferret model. I don't remember that we did that. But there is data to believe that the endocrine pancreas supports the exocrine pancreas.
Okay, so the follow-up was actually from your CFTR potentiator. Do you know if, again, in your model, it was shown whether it impacts the microbiome? I understand you mentioned that, how the association with the diabetes, well, in the gut, CFTR, the Ivacaftor, if that's I'm saying it correct. There was a couple of reports mentioning how it can lead to this increased presence of Akkermansia and such bugs which are perhaps good for the gut microbiome. But is there any relation from there to diabetes and on more?
You're asking about gut microbiome?
Yeah.
So that data is still pending from
I
the
see.
PROMISE study and from the BEGIN study. So the PROMISE study is a multi-center trial in older people with cystic fibrosis with the use of these medications, and then the BEGIN trial is younger, 2 to 5 years. And that data is still cooking.
I
We
see.
don't have it all back yet. The University of Washington is looking at that. We would expect that we might find something. That's why we put those endpoints in the studies. But the data has not returned. It's pretty complex when you're looking at that data. And of course, getting poop samples from people is hard, but you guys know that better than me. So yeah, that's still out there. We
Okay.
anticipate to find something, but you don't know until you check, right?
Okay. Thank you.
Great
Uh,
question.
We have to move on to the next people to ask questions. Please keep your questions brief to allow as much discussion in the room. Dr. Hussain.
Suhail Hussain from Stanford. What a wonderful session. I was really struck at Sushi by the data that you showed, which is that genetic etiologies of pancreatitis, particularly PRSS1, highly increase the risk of diabetes compared to non-genetic etiologies. I wonder if you adjust for the intensity of pancreatitis, including age of onset, recurrences, severity, and other factors, does genetics still predict the likelihood of developing diabetes with pancreatitis? If you follow my question.
Thank you very much for a very important question. Actually, according to our data, the onset of pancreatitis is earlier in patients with PRSS1-related pancreatitis. And actually, the severity, that is based on the number of attacks of pancreatitis, is higher. I mean, more frequent in PRSS1-related pancreatitis. So I think probably the intensity would have some role in the development of diabetes, but one increase, a final incidence is not so different. Actually, in patients with SPINK1-related pancreatitis, the cumulative incident risk of diabetes will increase even after 50 years. So actually, the risk is still higher in patients with PRS1-related pancreatitis compared to those without the pathogenic variant, but not so statistical difference between PRS1 and SPINK1.
Hi, Melina Bellin. So one quick question, one quick comment. So for Peter, that's beautiful data set you have, and I apologize if I missed this, but can you tell me, when you reference the C-peptide, is that just fasting C-peptide or what type of, just fasting C-peptide?
Yes.
Okay, so I think it's still really important data, and I think the caution I would say is that may miss early or more modest to moderate, insulin deficiency, and you'll see more severe insulin deficiency, I think, on your fasting C-peptide, but not earlier insulin deficiency. And then for Katie, I had not seen that ferret data where you withdraw the ivacaftor, which I thought was very fascinating with the recurrent pancreatitis, so not diabetes specific, but I would imagine that as we get more and more people on these, kind of starting early and lifelong, obviously we don't want to take anyone off, but invariably there's going to be insurance issues, there's going to be non-compliance, there's going to be people who could disappear from healthcare, so this would be something really interesting to look at in the CF and medical registries eventually to see if this happens in people as well.
So the thing is that right now the people who are dropping off are all people who are older who have complete exocrine loss. So we haven't done it yet in kids. So that's the thing we're all terrified about. Richard.
Rich Waldron from Cedars-Sinai. I also wanted to address a question to Peter and just praise you for this energetic series of studies. First, just a brief clarification. When you find higher insulin demand in the patient with higher CRP, is this immediately following an episode of acute pancreatitis? Did I understand that right?
Yeah, the last one during pancreatitis. So when on admission the patient comes, even with normal glucose level, no background diabetes, and the glucose starts rising, and we need to deliver insulin, administer insulin, the amount of insulin we need to administer is associated with the level of CRPR. So as high as the CRP likelihood, as much as insulin we need to give. So higher level of CRP needed higher level of insulin to keep the glucose level in a normal state.
Fascinating. My other question is to do with your model, the new model of toxicity. Are you extending the model to iron and ferroptosis and advanced glycation end products?
So I didn't understand the model for toxicity.
Toxicity, you talked about ethanol and smoke,
and
but are you extending the model to iron for ferroptosis mediated cell death and advanced glycation end products?
Excellent question. So what we have is stored the serum and plasma levels for all patients. So we will have a look different metabolism about which may suggest what's happening. We don't have tissues from human because they are not operated in acute pancreatitis, but we have the serum, and we already decided what kind of different pathomechanistic part, including even autoimmunity, free radicals, and so on, try to measure. I don't know whether we will be able to see in the blood, because in the pancreas we don't have a sample.
I think I have some of this evidence.
Minoti Apte from Sydney. Great session. Thank you very much to all the speakers. I guess I come from a basic science background, although I do have a medical background. But I was thinking understanding the pathogenic mechanisms is going to be important for novel therapeutics, right? So I have a question and a comment for Katie as well as Peter. So in the CFTR field, is there anything known about what stellate cells are doing in the field? Because I read somewhere that stellate cells are activated quite early, even in utero, and maybe you find them changed or activated that early time point. That means they must be doing something to the pathogenic mechanism?
That is a fantastic question. I know we looked at it, the ferret model. I don't remember what we found.
Okay.
So it's a great question.
Because you've got fibrosis in the adults
and
anyway,
the stellate
but
cells are
something must be
definitely abnormal,
happening.
but I can't remember. I don't think I'm making eye contact with yelling. Do you remember yelling? She's saying no. Okay. So I don't remember. I feel like we didn't chase it, so it must not have answered things, but I don't remember exactly what we found.
Okay, thank you. And Peter, thanks again for your great talk. You talk about the toxicity factors that Richard mentioned. So does alcohol have a direct effect on beta cell dysfunction, or is it always going to be this indirect inflammatory related things? And another question, corollary of that is, in your big patient population, are you able to study whether behavioral therapies might prevent not just the recurrent pancreatitis, but diabetes in these
I
patients?
wish I could answer it, but what we looked at, actually, we didn't go for preclinical models yet with whether the beta cell function, how much the alcohol toxicity or fatty acids affecting. We haven't looked at it. It's a very important question, and I'm not aware in basic translational research which covers this field. It could be an absolutely new field of research. Concerning the second part was
to see in your patient population if you had behavioral therapies that prevented them from drinking.
So what we could show that after pancreatitis, when we discharge the patient, only 3% glucose level is higher, which means the earlier idea that during a necrotizing pancreatitis, due to the beta cell loss, diabetes developing is not true. What is true that within 2 years, almost 70%, or even a single episode, over 50% became pre-diabetic. So something in the first 2 years happening. Either after a huge cytokine storm, the cytokine level maybe stay a little bit higher than earlier, or the fibrosis, the myofibroblast actually can go there, or it could be even the stellate cells. So there should be something happening inside the pancreas, which happening mostly in the first 2 years after pancreatitis.
But do these people continue to drink and smoke, or are they? So that's what I'm asking, whether you can...
We haven't this is an ongoing study, so we haven't had enough data to have subgroups of patients and showing if you adjust it for the toxic factor, it will be true or not. Of course, we need to complete the study. Thank you.
Please, if you can make it.
Jordan Wright from Vanderbilt. My question is for Dr. Larson. I'm sorry, I'm bending over so low.
You're too tall for the microphone.
You talked about the effect probably being on exocrine tissue, which then influences the endocrine tissue. The human islet studies you mentioned, knocking down CFTR and seeing a reduction in glucose-stimulated secretion. How do you square that? Or is that knocking down in duct cells that are carried along? Or?
Oh, okay. I'm supposed to be fast. So there's always duct cells in isolated islets. So that's the part I didn't get to say because I was trying to not go 15 minutes over my time. So the trick is there's no such thing as an isolated islet that doesn't have exocrine tissue, and that's one of the falsehoods in my field. So there's duct cells in those isolated islets, and that's where we're seeing the effect. Correct. Yeah. I didn't get a chance to yell about it because I can't yell about everything and get done in time.
We wouldn't do the panel a due justice if I don't ask one question to Kathleen. So Peter showed the data about a pro-inflammatory from a single episode, high CRP during AP, causing diabetes within the next 2 years. We looked at this from our metadata in children and found the same thing, a single CRP elevation, also interleukin-6 during AP episodes, carries the risk for diabetes even in regression modeling a year later. Can you allude from your experience on therapeutics how this could possibly provide for us avenues for investigating anti-inflammatory agents for pancreatogenic diabetes?
Yeah, I think it's an interesting question, and I can't possibly address that in every way that really would do it justice. But Certainly, there have been studies that have been done in type 2 diabetes, in the inflammatory milieu that is known as really more of a systemic inflammatory milieu, and some of these data have suggested that direct inflammatory inhibitors can be of use, and in particular with that post-insulin receptor signaling, but probably also within the pancreas as well. And we also know that many of the therapies that we use just for type 2 diabetes have some anti-inflammatory effects, and whether that's direct or it's the mechanisms are very complicated. But I think driving down on a specifically in the islets would be definitely a particular avenue for therapeutic advancements.
Yeah, and future investigations. Let's thank our panelists one more time. We'll invite the next session co-moderators to the stage. Thank you.
Good morning. Okay. Good morning, everybody. I think I want to keep us on time and be respectful of everybody's time, so I would ask if people would be kind enough just to take their seats. It's my great pleasure to introduce the next session, which is on diabetes and pancreatic cancer, on behalf of myself and Dr. Cork, who are the moderators. And I'm going to start off by introducing our first speaker, Dr. Suresh Chari. Dr. Chari is a professor in the Department of Gastroenterology and Hepatology at MD Anderson. He has served in multiple leadership roles, including as the prior president of APA, IAP, and editor-in-chief of Pancreatology. His research has focused on the connection between new onset diabetes and pancreatic ductal adenocarcinoma. And we are absolutely delighted to have him here joining us to talk about the epidemiology and clinical profile of diabetes and pancreatic cancer. Welcome, Dr. Chari.
Thank you, Anne-Marie and Murray, and thank you for the APA for the opportunity to speak today. So I'll be talking about the connection between diabetes and pancreatic cancer and convince you that pancreatic cancer causes diabetes, and this has clinical implications. So I'll start off by giving you an overview of what happens with diabetes and pancreatic cancer, the complex interaction, and sometimes not always understood. So long-standing, you just heard Atsushi giving you a wonderful talk on the Japanese experience with diabetes and pancreatic cancer, so some of this has been covered. But long-standing diabetes has a modest increase in risk of pancreatic cancer, and this is largely an epidemiologic finding, but there is data coming out that weight loss can prevent pancreatic cancer, and there is some preliminary evidence that in those who have bypass surgery and have remission of their diabetes could have a lower risk of pancreatic cancer. So there is some preventive aspects to this connection that are useful to know, but from an early detection standpoint, this risk is too low for us to be benefit from it. But more importantly, the cancer, once it develops, causes metabolic dysregulation in nearly all patients. And it leads to new onset glycemic abnormalities in the subsequent months to years after the cancer has developed. And this leads to not only new onset diabetes, but new onset pre-diabetes and worsening long-standing diabetes. So there is a full range of abnormalities that occurs due to the diabetogenic effect of pancreatic cancer on glucose homeostasis. So I will be focusing on the effect of pancreatic cancer on glycemia, and this all happens mostly in the pre-diagnostic state of the pancreatic cancer, because by diagnosis, there's tremendous abnormalities and tremendous progression in the cancer, so we are interested in the pre-diagnostic state. What we have done over the years is studied both the pre-diagnostic phase as well as the studies at diagnosis. So I'll give you data on fasting glucose level trends before diagnosis, fasting glucose trends by tumor volume, and risk of pancreatic cancer and new onset diabetes. And at diagnosis, we have looked at fasting glucose by tumor volume, the FBG before and after resection of cancer, and the proportion with diabetes at diagnosis in those who have clinically diagnosed pancreatic cancer. So let's look at temporal trends in glycemia and pancreatic cancer. So this is an Olmsted County study that looked at about 215 pancreatic cancers diagnosed in Olmsted County between 2000 and 2015. So this is a population-based study of every single pancreatic cancer that was diagnosed in this area. And there are twice the number of controls. And we abstracted the fasting blood glucose up to 5 years before diagnosis, and then plotted those glucose values over 5 years up to diagnosis. And you will see here that the glucose in pancreatic cancer cases diverges from the controls between 30 and 36 months before diagnosis. And it crosses diabetes thresholds around 9 months before diagnosis. And at diagnosis, 40% of pancreatic cancer patients have diabetes in this study. This was recently confirmed in a UK study that looked at A1C trends over time and came to the same conclusion that A1C starts diverging from controls around 30 to 36 months before diagnosis. So very nice validation of our study in Olmsted County. So the graph that I just showed you suggests that a smaller tumor would cause less increase in glucose, and as the tumor grows, the glucose also goes up. So we tried to test this in resected patients and dividing them by their volume. So this is an interesting state. This is a subset of the same patients I showed you, but divided by the tumor volume at diagnosis. And when we went back in time, the smaller tumors caused a smaller rise in glucose at the time of diagnosis compared to the larger tumors, which caused a bigger swing in cancer at diagnosis. So again, suggesting there's a volume FBG correlation that is there in these patients. This is a time trend, but this one is based on volume of the tumor at diagnosis. So every tumor in Mayo Clinic, until about 2015, patients were resected without getting neoadjuvant therapy. And when you resect the tumor, you get a three-dimensional numbers from the pathologist, X into X into X. So we calculated the volume based on that, and then divided the tumors into those less than 0.5 cc, and then every doubling of the tumor following that, and plotted the fasting glucose at diagnosis in these cancers. And we show a progressive rise in glucose as the tumor volume increases. And what I call VHG is the volume at which hyperglycemia is noted higher than in controls is around 1 to 2 cc. And you see the VDM, which is the volume at which diabetes thresholds are crossed, is around 4 to 8 cc. So these are small tumors that are causing hyperglycemia, and even diabetes is, and an average volume of a tumor at resection is around 12 cc. So you start to see that this is happening at a time when we should be able to make a difference for the patients. So we also looked at pre and post PDAC resection to try and see what happens to the cancer. So if you step back a little bit, you're removing 1/3 of the pancreas in a person who has diabetes. You expect the diabetes to get worse. This is what happens. every single case you see there is a drop in FBG post PDAC resection. Whether it's in the head or body tail, whether it's a Whipple or distal pancreatectomy, there is a dramatic drop in fasting glucose post-resection of the tumor, suggesting that the tumor was involved in the hyperglycemia, which gets better post-resection. What about prevalence of diabetes at PDAC diagnosis? This is now we have shown this in multiple data sets. This was an original study where we looked at 512 pancreatic cancers and 900, almost 1,000 controls, and looked at the distribution of the glycemic status at diagnosis. And you'll see that normal fasting glucose is the majority of patients in controls, but that drops to 14% at diagnosis. And the diabetes from 7% goes to 47%. Nearly half the patients have diabetes. And nearly all patients with pancreatic cancer have an abnormal blood glucose. This is a striking finding of this study, is that 85% of people with pancreatic cancer have an abnormal blood glucose at diagnosis. This was again done in the Olmsted County cohort, and we basically found the same thing. In a population-based study, we found that nearly half have diabetes, another 13% have advanced prediabetes, and only a small proportion have normal fasting glucose at diagnosis. So a dramatic, very powerful disruptor of glucose homeostasis is pancreatic cancer. So all this led to our question of whether, if diabetes is so common in pancreatic cancer, would pancreatic cancer be more common in new onset diabetes? So this has been a question that we asked many years ago, and answered this question in a population-based study back in 2005, where we had 2,000 new onset diabetes subjects. So you must remember here again that all these studies are based on a glycemic definition of diabetes. That is, the day they cross diabetes thresholds based on fasting glucose and or A1C thresholds, that's when we counted it as new onset diabetes, not the day they got diagnosed with pancreatic diabetes by a physician. So in this cohort of 2,122 subjects with glycemically defined new onset diabetes, 0.85% were diagnosed with pancreatic cancer within 3 years of meeting criteria for diabetes, which is about an 8-fold higher risk compared to the general population. So this was 2005. It took 20 years to prove this prospectively. So this is a prospective study. It has 8,838 patients. Mean age is 63, and there's a variety of different racial ethnic groups in this, and now it becomes very meaningful to look at the racial ethnic differences based on new onset diabetes. So this is actually published now, and it's going to come out this month. So this is a 3-year risk of pancreatic cancer in this cohort, and you'll see that in whites, which is majority of the Olmsted County population, the risk is exactly the same as what we saw 20 years ago, 0.84%. And in whites, in Hispanics and African Americans, is half of what we see in whites. It's 0.37 and 0.4. I can discuss more about this in the discussion if there is an interest, but there is a partial explanation for this, not a complete explanation, for this dramatic difference in racial ethnic risk based on race and ethnicity. More important thing is also, as important is the lead time distribution. And we found that, just like we have shown in the fasting glucose graphs, that the lead time to diagnosis from diabetes is median is 8 months. 0 to 4 months is 30%, and 70% are more than 4 months from the date of glycemically defined new onset diabetes. And we believe this 4 months gives you a fairly significant opportunity for intervention and earlier detection if acted promptly on the glycemically defined new onset diabetes. So in summary, what we have shown is that PDAC causes glucose dyshomeostasis starting about 3 years before diagnosis. It occurs in nearly all patients, with 20% having new onset diabetes, and the hyperglycemia gets better when we resect the tumor. And clinically important question is the 3-year risk. And we believe there is an actionable 3-year risk of pancreatic cancer, which occurs with sufficient lead time to give us an opportunity for an intervention here to make earlier diagnosis of pancreatic cancer. Lots of people to thank here, organizations and funding agencies, and I appreciate the opportunity to give this talk. Thank you.
The next speaker is a friend, a colleague, and a true gentleman. He's professor of medicine in the Division of Gastroenterology and Hepatology at Ohio State. He also serves as the director of research in that division, as well as the assistant program director for medical pancreatology. And he's done very elegant work in relation to pancreatic cancer and diabetes.
All right, thank you. It's really a great honor to be here today. It's a gift to be sandwiched between two collaborators and good friends. But thank you to the meeting organizers and the session moderators. So I've been asked to talk about mechanisms of pancreatic cancer-related diabetes, which is really the heart of this session. These are my disclosures, none of which are related to the current topic. One important disclaimer, though, is that I'm not an endocrinologist, so I am an internist at heart and dabble with diabetes, but so... Nobody's That's right. All right. So I like the organization of this session because we're really touching on multiple questions related to this topic. I'm going to spend a little bit of time pitching my answer to the question of what is it, how do we define it. Suresh has just really outlined a compelling case for why we should care about it, as well as portions of the clinical profile. I'll talk a little more related to how we think it happens, and then Dr. Cruz will be talking about the obesity connection with this. So one of the things that's made this so difficult to study and try to understand over the years is that it's taken us a while to appreciate the bidirectional relationship whereby diabetes can be both a cause as well as an effect of pancreatic cancer. And Dr. Masamane used this metaphor earlier of the chicken and the egg, but I'd like to pay homage to Dana Anderson, who originally applied it to this topic about 15 years ago. But so as Suresh outlined, though, I think we're seeing and understanding more and more of how and understanding how the cancer can directly cause diabetes. So in terms of what is this situation? So I don't know how to define it, to be frank, but I think there are a couple characteristics that I think when we're talking about this, we're all sort of referring to. The first is that we think that the diabetes is mechanistically attributable to pancreatic cancer, or at least we have some good suspicion to do that. So for clarity and scope, we're not talking about a situation where a patient has or develops diabetes after pancreatectomy. Suresh again showed some data showing that the diabetes can reverse in some, but it's not universal, and there are some patients who will develop new onset diabetes post-operatively. So we're thinking about that we have some reason to suspect that the tumor is causing the diabetes. The second is that there's some type of chronological proximity to pancreatic cancer. And again, Suresh has outlined the case related to new onset diabetes. This is some older work from his group at Mayo, again, showing over and over again that there seems to be this divergence that starts to occur and be visible about 36 months before cancer diagnosis, where the rates of diabetes in those patients with pancreatic cancer compared to non-cancer controls seems to diverge. So again, we're not talking about, and for the remainder of the time here, I'm not talking about the patients with long-standing diabetes, whether it's type 2 or type 1. Now, I'll also, again, just acknowledge that really pancreatic cancer-related diabetes, I think, is still just a conceptual entity. This is not a diagnosis yet. This is, I think, for many of us, we view this as the holy grail, something that we're all chasing after, but is really elusive and difficult to pin down. And so it takes a lot of different vantages to I think, try to tackle this question. Now, before I try to answer the question, how does it happen, I want to, especially after some of Suresh's comments, talk about how it does not happen, and that is that pancreatic cancer-related diabetes is not due to severe gland destruction. So a couple comments here. So first is that when patients who have pre-diagnostic scans are reviewed, this is really how we're learning these lessons. And when the diabetes develops, and especially once hyperglycemia, which precedes the diabetes diagnosis, there's often no visible tumor at all. And for the non-gastroenterologists in the crowd, it's important to realize that in pancreatic cancer, if and when you do have pre-diagnostic scans and you go back and look, say, 6 months before the symptomatic presentation that gives them the diagnosis of pancreatic cancer, oftentimes you would see a small tumor, or things would look quote unquote normal. At least they would look normal to the naked eye, right? There's a lot of AI work that's going on which will hopefully help us understand that a little bit further. Now, I want to be clear though, because this may seem dissonant with one of the comments that, that Dr. Chari was putting forward, where he showed that the tumor size is associated with hyperglycemia. That is a true statement, and this is also a true statement. The situation, though, is that the volume threshold for diabetes onset is still, for the purposes of pancreatic cancer, you know, if you line up all the pancreatic cancers, they're still relatively small tumors. Okay, so again, this does not provide us a sufficient explanation for how pancreatic cancer-related diabetes happens. Now, again, to return to the clinical profile, because in some regards, this is sort of a roadmap. You know, if we're trying to understand how this happens at a mechanistic level, whether it's preclinically or in human studies, these are the things that we have to explain. So first, there's overlapping risk factors with the canonical, you know, type 2 diabetes risk factors. Second is that there's a high proportion of these patients who require insulin treatment. Thirdly, many of these patients are experiencing weight loss that even precedes the diabetes onset or hyperglycemia. When we look at the soft tissue changes, there's tends to be more loss of adiposity. And then lastly, there are alterations of glucose metabolism. And historically, and I'll raise my hand, this is a quote from one of our articles, is that this was described as being associated with hyperinsulinemia that was secondary to insulin resistance. I'll come back and present a counter story to this quote. So as it relates to the potential mechanistic contributors to PDAC-related diabetes, there are different categories and domains that we can think about, and I've sort of spread them out here. The thread that I want to pull on a little bit more in the next few minutes relates to glucose homeostasis. So, and importantly, we're talking about, and we're always comparing and thinking about pancreatic cancer-related diabetes compared to type 2 diabetes. As Suresh really laid out nicely, this is the haystack that we're hunting in when we're thinking about early detection of patients with pancreatic cancer diabetes is amongst those adults with what is otherwise presumed to be type 2 diabetes. So these are really the key comparison groups. The existing paradigm has been that, well, there's an overlap in clinical profiles, risk factors, so we need to find some other, you know, disease factor, biomarker, whatever, to try to separate these groups apart. As I mentioned, historically, the working belief has been that the predominant defect in pancreatic cancer-related diabetes is with insulin resistance. And this is supported by studies, which I'm not showing here, which have shown that preoperatively patients have insulin resistance, the tumor is resected, and then the insulin resistance improves. So this and other questions were what we were interested in understanding in the DETECT study. This is one of the core studies of the Consortium for the Study of Chronic Pancreatitis, Diabetes, and Pancreatic Cancer, or what's now rebranded with a different long name. But at any rate, within the DETECT study, patients were invited to participate across all different, you know, disease-related groups. They all underwent a standardized 2-hour mixed meal tolerance test. For the patients with pancreatic cancer who were enrolled, they were 100% were treatment naive. Dr. Chari showed data related to improvements in the glycemia that can happen after surgery. This also happens following effective chemotherapy as well. So all of the patients, though, studied here, treatment naive, and then the diabetes duration for this analysis that I'll be showing data from were all in the quote-unquote new onset diabetes time frame defined as less than 3 years, although the actual average was about 12 months, so even a shorter time frame. Well, this was an analysis that was really championed by Fred Toledo, an endocrinologist from UPMC, and he really helped to make some really interesting and we think provocative findings. But the bottom line is that we observed that pancreatic cancer-related diabetes and type 2 diabetes differ in multiple aspects of glucose homeostasis or metabolism. Now, these are some curves here showing the temporal trends between the two groups. The pancreatic cancer-related diabetes group is shown in the red line. And the nice thing about these data is that you don't have to be an endocrinologist to understand that they're different, right? So the glucose curve, excursion curves look very similar. But then when we look at insulin and C-peptide, the levels were substantially lower for the pancreatic cancer participants. Now, this is not really how endocrinologists think about homeostasis, and so we used a number of derived indices to try to better understand some of the different insulin traits. Firstly, when we look at insulin sensitivity, which it's a little tricky, but it's effectively the inverse of insulin resistance. But when we think about insulin sensitivity, as I mentioned, the prevailing paradigm before was that that in pancreatic cancer-related diabetes, it was predominantly affected by insulin resistance. This is actually not what we saw. So these data are illustrate the index from the man, it's hard to see. Yeah, the y-axis label. Sorry about that, guys. I had updated slides, but I didn't hit the deadline. But anyway, this is with the Masuda index, and you can see they're substantially different between the two groups. Similarly, when we look at insulin secretion, significantly lower in the pancreatic cancer-related diabetes group. And then these two entities are related, but there's a third concept, which is beta cell dysfunction, which takes into consideration the insulin secretion, and this is a classic endocrinology thing, understanding whether it's appropriate or inappropriately low or wherever. But at any rate, so this is a calculation of the insulin sensitivity and insulin secretion for the oral disposition index, and again, you can see that the beta cell dysfunction and the pancreatic cancer-related group was significantly lower. All of these analyses were adjusted for age, sex, BMI. We did a number of sensitivity analyses, looked at different matching strategies of simple case control, propensities matching, and all of the effects remained persistent. And then lastly, we also took a look at alpha cell function as measured by the postprandial glucagon levels. And when all of us eat, it's expected that the postprandial glucagon levels will drop. This is abnormal in the setting of type 2 diabetes, and we also saw that this is actually, if anything, is more abnormal in the pancreatic cancer-related group. So a number of different elements that we observed in this really, we think, clean comparison, sort of head-to-head, is that in the pancreatic cancer-related diabetes group, there was much more severe beta cell dysfunction. The insulin resistance was actually less severe than in type 2 diabetes. This was counter to some of our original hypotheses. I don't show the data related to insulin clearance, but this was also higher in the pancreatic cancer-related diabetes group, and this is not what we would expect in a state of insulin deficiency. And then lastly, as I mentioned, we also observed that there's alpha cell dysregulation in pancreatic cancer that contributes, and this was not explained by incretin deficiencies. All right, so where to next? Well, so first off, I apologize. I put these slides together a couple days ago, and I realized the airplane may be triggering for some of you, but glad everybody could make it. But there are a lot of places that we can and should go, and this is a both and. We all need to be working together. This doesn't, in my view, this doesn't close any doors. There's a need definitely for validation of the things that we've seen in larger studies. There's certainly within group variability, and for pancreatic cancer, for the biologists in the room, you understand there's a lot of heterogeneity with the tumor itself, so it's not, wouldn't be surprising to observe that in metabolic studies. There's definitely opportunities for more detailed physiological studies. I put a question mark though, because to be frank, doing these studies, even a 2-hour research visit for these patients with treatment-naive pancreatic cancer who are facing a potentially terminal diagnosis, is a very difficult ask and an extreme act of generosity from the participants. So the idea of these patients coming in for a 4+ hour clamp study is really difficult, to be frank, to see that happening. But I do think it really continues to push for further investigations for mediators and other diagnostic biomarkers. Now, I know what many of you are thinking. The question is, isn't this just a fishing expedition? We've been doing this for decades. We haven't found anything yet. I'm maybe not that cynical about this topic because I think that with some of the observations that we're making related to the clinical and metabolic profiles, it can hopefully allow us to be more targeted. Perhaps we may still be using sort of shotgun or agnostic, discovery techniques, but as it relates to coming time to identify candidate markers to look for and to include in different panels or in validation studies, I do think that these insights that we're sharing are instructive. And I don't have time to go into, but there's many biomarkers at different stages of, green light go, red light stop. but there's lots of work that many in the room have contributed to and that we all need to continue toward. And really the punchline that I want people to walk away with is that pancreatic cancer-related diabetes is not the same at a metabolic level as type 2 diabetes, and there are multiple different aspects. So I'd like to acknowledge and thank my team at Ohio State for all their support, also for the DETECT study. Especially want to appreciate all of the DETECT study, PIs, everybody who has made that study possible. And then lastly, since I have the mic here, personal comment related to Dana. I think many of you may know that we and our sort of quote-unquote destinies were joined together forever by Suresh, actually, related to this hormone of pancreatic polypeptide. And that's a baton that I've, I guess, been figuratively passed and will gladly carry on. But one anecdote that I want to share that most people may not know about Dana relates to this article that we published as a review from the consortium in the first issue of the GI subjournal of Lancet. And hopefully people are familiar with this. Again, we need to correct some of the things that we wrote there as we're learning more. But I think one of the things that I'll always remember about Dana is that this article was actually solicited for him. So he was asked to contribute the article, and within the hour of getting the invitation, he'd already reached out to me and others in the consortium to say, hey, this is a great opportunity for the consortium, let's do this together. He invited and gave me the opportunity as junior faculty to be a big part of this, and other junior faculty were included as well. So again, I think doesn't show up in citations or grants or any of that sort of thing, but I think for me this is what I'll always think about when I think about Dana. Thanks.
Thank you so much. It's my pleasure to introduce our last speaker, Dr. Zobeida Cruz Montserrat. Dr. Cruz Montserrat is a professor in the Division of Gastroenterology and Hepatology at Ohio State, where she directs basic science research and co-leads molecular carcinogenesis and chemoprevention program. A major focus of her research is in obesity-associated pancreatic adenocarcinoma, and we're delighted that she's able to join us today to discuss mechanisms by which obesity, fatty pancreas, and diabetes are associated with pancreatic adenocarcinoma. Welcome.
Oh my, thank you very much. It's a great pleasure to be here. Thank you to the organizers for inviting me to speak at this pre-meeting. I have some big shoes to fill going after these giants in the field, especially as it relates to patient care. Again, disclosure, I don't have none, but I am not an MD, I'm a PhD. So I try to make sense of things in the lab, and thank you for resetting the timer, because if not, we're gonna be here forever. And you don't want that, you want a break. Okay, so I was asked to speak about the mechanisms of obesity-associated pancreatic cancer. Has been the focus of my lab for many years. As we know, there are many known risk factors for developing pancreatic cancer. Some of them are actually modifiable, and we think obesity is one of them. However, we still don't understand precisely what those mechanisms are, nor what is it about obese patients that, we don't need a biomarker of obesity, but what is it about those patients that develop PDAC due to this risk too? So as we know, the percent of obese individuals in the world, especially in the United States, have increased over the years, specifically in the United States, and sadly, this is also being shown in young adults as is being tracked, which is concerning as the population in the world or in the United States have not been able to control obesity over the years. There are about 13 types of cancer that are associated with obesity, pancreatic cancer being one of them, and the focus of this talk. And as we all know, pancreatic cancer is projected to increase in death be the second leader of cancer death by 2030, and it's thought to correlate with these obesity trends over time. However, so far it's been only correlations, no causations. As you can imagine, trying to understand how a normal pancreas developed into pancreatic cancer and whether and obesity-associated pancreatic cancer is different molecularly than those that don't arise from obese patients is very complicated. And we actually rely on mouse models to be able to make that connection. And my lab is very cognizant of making sure that what we study in the mice we can actually translate, because we can only go so much with the patients. As you heard, it takes years for these tumors to develop in the actual population, so you can imagine the challenges that we have as to how we can study. And I will try to bring those up as I go and show you my story. I'm not the only one that is interested in this, of course, which is a good thing. We need multidisciplinary minds and teams to study this. This is not meant to be written for you to read it. It's meant to show that there's been some efforts in trying to look at specific molecules that are factors that lead to this risk. Many of them are involved and related to inflammation, as you can imagine. Our lab in particularly has focused on this molecule called lipocalin-2, LCN2, NGAL, if you're in the clinical setting and know it by that. Is a pro-inflammatory molecule that actually is known to bind iron, which is very interesting, is its role in ferroptosis in cancer, and other lipophilic molecules that are associated with cancer and multiple other inflammatory diseases. It also is very known to sequester iron to prevent bacterial infections, but it has a role in tumor progression and neutrophil infiltration in many inflammatory diseases. Early in the days of my lab getting started, we actually found that pancreatic patients, specifically metastatic pancreatic cancer patients, their blood levels of LCN2 was highly upregulated in these patients. As a matter of fact, also in chronic pancreatitis, which is another study that we have ongoing in the lab. When we actually look at the tumor of pancreatic cancer patients, now I want to keep in mind, these are resected patients, not the metastatic patients, but it's the tissues that we have available to actually look. We see that lipocalin is one of the highest upregulated compared to normal pancreas or patients without disease. But you please keep in mind that this is part of a big family of lipocalin proteins that are known to be lipophilic. So with that in mind, these initial studies did not actually compare resected versus metastatic patients' levels and or the obesity status of these patients. And so we set up to do that, and I want you to appreciate how big of an endeavor this is and how multidisciplinary it is in order to collect healthy controls, stratify them by BMI, treatment-naive patients, specifically since it was mentioned that most patients are not treatment-naive because they get treated with neoadjuvant, especially if they're going to be resected, and then, of course, metastatic patients. And we did our best to stratify with BMI, and for this we're using the cutoff of 30 for BMI. Now, the interesting thing about this was that what we saw was that LCN2 was high mostly in metastatic patients, and it had nothing to do, or at least we couldn't see at this stage how it was doing, it didn't associate with the obesity status. However, we don't think that the circulating levels of this molecule provide information about the changes related to the molecular signaling pathways about this molecule. There's a lot to see within the adipose and the tumor microenvironments that could lead to this risk. And so we set up to find, is there other factors related to the signaling that we can appreciate? As you can see, we all think, especially if we're in the pancreatic cancer field, we think about how the tumor microenvironment is heterogeneous, where if you go now into the obesity field, you actually know that the tissue of the adipose tissue is not just one cell type. There are multiple cell types in it, which is something is very interesting and endeavor for my lab. But it's been shown that this molecule can actually be secreted by adipocytes and other cells within the adipose microenvironment. So interestingly, it is known to alter signaling by its capacity of binding multiple fatty acids and then shuffle those fatty acids into tumor cells. And so we set up to leverage our resources and look at Ohio State for many years. They've been collecting adipose tissue from patients that undergo a pancreatectomy resection in the Department of Surgery. And so we actually took those tissues and we look for the expression of the receptors of LCN2. There's two known, SLC22A17 and NC4R. And one of the things that we notice is that when we stratified by obese versus lean individuals, the levels of the receptors were changed in the tumors, which was interesting. However, we also had subcutaneous adipose tissue from these patients, and in here, we actually see the increased expression in LCN2, but a decrease in different levels of the receptor. And interestingly enough, the visceral adipose tissue also gave us different answers. So this is where this data suggests that there's a tissue-specific modulation of LCN2 that might be key to targeting the pathways in obesity-associated PDAC, try to understand that at the mechanistic level. Now, interestingly, I mentioned that LCN2 can bind certain fatty acids, so we actually set up to look at some abundance of fatty acids that were specific to this resected patients, not normal pancreas versus PDAC, but only resected patients with PDAC and the BMI of these patients. And we saw that two pathways related to linoleic acid were, which also binds LCN2, were upregulated related to obesity. Now, these levels were modest, and multiple comparisons kind of kill this a little bit, but it was just interesting to see that some of these associations that we have known were actually there. However, to dive in the tissue-specific mechanisms, we can only go so far, and this is where we have to leverage the mouse models that are out there. And again, we actually leverage one of the most commonly used mouse models, which is models of diet-induced obesity, and to try to correlate, like, do these changes that we see in the humans, are they seen also in our models of obesity-associated pancreatic cancer, and can we modify them to try to get towards more specific mechanisms in those models? And so while there are multiple models of studying obesity in mice, like the OB mice, diet-induced obesity is one of the most common, and I know many people in this room have used that model to study similar pathways. This is trying to mimic the Western-style diet of many individuals that is associated with obesity. It's high refined sugars, low in fiber and proteins, high in carbohydrates and saturated fats that lead to this increased inflammation, insulin resistance, and weight. And so when we feed mice that are predisposed to develop pancreatic cancer by inducing the endogenous levels of KRAS in the pancreas, and we feed them a high-fat diet, we see that these mice actually do get obese. By only 30 days on the high-fat diet, they actually start developing the prenoplastic lesions and develop cancer, and their survival is less. And so we actually set up to look at the pathways in the adipose tissue of these mice, specifically the gonadal adipose tissue, because the depots in the mice are very different than the humans. But we saw multiple inflammatory and fatty acid biosynthesis pathways that were interesting. Now, among those fatty acid pathways, again, were those linoleic acid pathways, many fatty acids related to the linoleic acid that can actually bind LCN2. And so we have actually shown that LCN2 is actually increased in this model in circulation after you feed the mice a high-fat diet. And in the pancreas tissue, we actually see an increase in the secretion also of LCN2. When you actually remove it systemically in the mice whole body, you actually see that these mice actually they delay in their survival. So they actually survive longer when you lack the expression of LCN2. And we associated this with decrease in immune cell infiltration, such as macrophages and others, which is already published, so I'm going to skip through a lot of the data that was done. However, it was unclear how systemic changes contribute to that interplay between the adipose and the tumor microenvironment, and how it might impact tumor infiltration. So we actually isolated stromal vascular fractures from the adipose tissue to look to see if LCN2 modulated specifically signaling in those adipose-specific cells. and saw that transcriptomically there were very interesting differences because of the lack of LCN2. At the protein level, secreted molecules were changed, including molecules associated with inflammation. And also, this is a cytokine array looking at similar things. We actually can validate that LCN2 was not being secreted, which is good, but also, interestingly, highly secreted molecules related to angiogenesis, among others. I'm happy to collaborate with anyone who might be an expert in any of these molecules, because we cannot all do everything. So I'm happy to share some of this data. However, the adipose-derived LCN2 signaling might be a key driver to inflammation, so this is encouraging. However, there's still a lot to do. So briefly, we've actually modulated removing the expression of LCN2 specifically from adipocytes using a transgenic model that deletes a Krelok stop model that deletes LCN2 specifically for adipocytes. In this model, we already know that the DIO model, the adipocytes also express LCN2, so that was the premise of doing that. And when we do that and we inject cancer cells orthotopically, we see a reduction in tumor growth. But this is only in tumor growth. We're working to see if this also affects initiation, which creates more complicated genetically engineered mouse models. So hopefully I can update you on that later. However, LCN2, I tell you, this is some of the signaling that I think is happening, but we still don't feel that we have the big picture. And so there's also this theory that there's bidirectional signaling between the pancreatic tumors, stromal cells, and the adipose tissue to establish this pro-tumorgenically microenvironment niche. And for that, we have to move a little bit more into sequencing individual cells within the adipose tissue to try to tackle that. And I show you a little bit here of some of the work that we have done to try to see if we can reverse obesity-associated PDAC by doing either diet-induced weight loss interventions or diet-induced weight loss in combination with increased physical activity, which is a study we published in Cancer Research last year. And when you actually do those interventions, you actually see that you modulate and remodel the expression of multiple genes in the adipose tissue, including the secretion of LCN2 goes down in those models, which we felt was very interesting, and cytokines like IL-6, who is known to be pro-tumorigenic. Now, I'm going to leave you with the last slide and piece of data that is just the beginning of multiple collaborations, and that is when we actually look at the single cell level, we actually see a total remodeling of multiple types of cells within the adipose tissue, including decrease in adipose-related MDSCs, which we felt is very interesting. Now, I can go as fast as the bioinformaticians to answer all of the questions that I have about this, but I think this is going to be a link to what I'm going to talk about on Saturday on my talk there. But I want to leave you with, we can understand all these pathways that could, maybe or not, I still don't understand what LCN2 is doing. There's a lot of hypotheses that we're trying to test, but I don't think the mechanisms are going to be the same in terms of initiation versus whether the person comes into surgery and they're obese versus lean. I think those are totally different mechanisms, and I'm going to leave you there because there are a lot of technical challenges that we have to be able to study this. So again, I want to acknowledge that this is a multidisciplinary team. It takes GI division of these patients that are at high risk of developing PDAC. It takes medical oncology for these patients that are being treated, that are metastatic, to be able to do these comparisons. It takes surgery for those that go into surgery. It not added here, but it also takes radiation oncology to then see the effects of radiation. And big efforts between all these three departments, institutions, divisions within The Ohio State University. So I stopped putting names because there were so many people involved in this process. And I'd like to acknowledge the lab members that have come and gone, and the current members and the funding agencies that have helped us do some of this work. I would like to end to say that I think a lot of this is very cell-specific, context-specific. What LCN2 could be doing in the adipocytes versus the stromal cells versus the tumor is very different, and we're still in the process of understanding what is going on. But thank you very much.
Thank you so much. I want to thank all of our speakers for not only being on time, but actually ahead of time. So we have just over 10 minutes for questions. And Maybe I can start off our questions by just asking Dr. Chari, you showed a very interesting graph from your recent gastroenterology paper, which showed dramatic differences based on race and ethnicity. Maybe can you comment a little bit more on that?
Thank you. Yes. So one of the surprising findings of the study was that there was a dramatically lower risk of pancreatic cancer in those who were Hispanic and African Americans. But one of the key differences between new onset diabetes in general between Hispanics and African Americans versus whites is the age of onset of diabetes is significantly lower in minorities. In fact, if you look at the data, between 40 and 45% of patients who are Hispanics and African Americans are between 50 and 60, where the risk of pancreatic cancer is much lower. It doesn't completely, we did the age of onset adjusted risk. It compensates somewhat, but doesn't completely explain the reduction in the risk. So there is a partial explanation in that the age of onset is lower, and therefore at that time pancreatic cancer is not as common, but it doesn't completely explain the risk.
Would you like to come up to the microphone, just give your name and your institution, then please ask your question.
Here you go.
Closed it for me?
No, not for you. I mean the session. But
This is Som here from the Department of Surgery, University of Miami. Again, big gratitude to all because we young buds, we are standing on the shoulders of giants. First question to Dr. Cruz. In your LCN model, I don't think, did you show whether how long the mice do end up surviving the KPC crossed with the LCN2?
Yeah, they actually survive maybe, I can't remember the numbers, but it was statistically significant. They can survive, I think the KPCs can last about 3 months in our colony. They can survive past 3 months on the high-fat diet.
So
and also without the high-fat diet, they actually live longer.
Oh, that is interesting.
And actually, I should mention, this is not the KPC, this is the KC model. So you gotta remove P53. We get a different phenotype if we have P53 in the mixture mutation.
So there is this, I don't know who was the stellar scientist who coined the term the obesity paradox. So in these conditions, there is increased immune checkpoint expression. So I'm just curious that if there is more increased expression, if you couple your model with immune checkpoint blockade, do you see long tail as we see in patients with
We're working on things like that with more smart people who are immunologists. One of them is in this room. I'm not an immunologist, but yes, we have actually so targeting LCN2 has been a long-standing question in the field. How do you target it as a secreted molecule? Some people use antibody blockades for that. And if you do it, you actually reduce the chemoresistance specifically to gemcitabine. And as a matter of fact, when we did that, you actually see increase in the T cell, CD positive T cells that are CD8 positive T cells. And so we think that it will improve immunotherapy. So it's an aim of multiple versions of a grant that we have written. So we will be looking into that.
Thank you. We'll move to the next question. Thank you.
Thank you. All the great talks. I'm a surgeon. My name is Chiang Xu from Peking Union Medical College Hospital. I have a question for Professor Cherry. In your talk, you referred to after the pancreatectomy, resect the tumor, the glucose will decrease after the resection. I made a cohort based on my patient. It's small. I want to detect the exome differences before or after the resection to detect whether there is some difference on the exome. But it's a pity. I didn't find any patient will have their diabetes remission after the distal pancreatectomy. Maybe 30% they will have their diabetes remission after Weber procedure. do you have the comments? Maybe it's a small cohort. Do you have the cohort that after the distal pancreatectomy, the diabetes remission can occur?
In our data set, we showed the reduction in fasting glucose in both categories. So when we looked at the complete resolution of diabetes post-resection, and I looked at the duration of new onset diabetes, I found that if the duration of diabetes was longer than 12 months, there was significantly less likelihood of the diabetes resolving post-resection. So the shorter the duration of diabetes, more likely you'll have a response. One of the factors that could be there with distal pancreatectomy would be that these tumors tend to be larger because they are, and you're maybe resecting more of the pancreas. That I don't know. But in our study, we neither saw a difference in prevalence of diabetes between head and tail, and also saw a consistent drop in fasting glucose post-resection, whether it was head or the tail. So.
Okay, thank you.
Can I just add something?
Yeah, please.
So in humans, the tail has more islets per cubic centimeter of volume than the rest of the pancreas. It's much richer with islets. So the original surgeries that were done in early PDAC always kept the tail behind. And these people actually had a long time of not having diabetes because of that residual thing. And the reason why this is interesting is in evolution. Birds and mammals are the only ones that have dispersed islets throughout the pancreas. But there always seems to be more in the tail, and that started with reptiles. Reptiles also have dispersed islets, but more in the tail. So there's something about the developmental biology of the pancreas that makes for these differences.
Thank you.
Good morning. I'm Xianzi Wang from Peking Union Medical College Hospital, and my question is to Professor Cherry and Professor Hart. So given that the type 2 diabetes and pancreatic associated diabetes have different etiology, and we can assume that these two cohorts or different patients have different glycemic spectrum. I mean, I noticed that Professor Cherry used the FBG in your NPAC model. So is it possible if we use the continuous glucose monitoring system to have a more detailed spectrum of the glucose, and maybe we can use more parameters to make more deeper analysis to the spectrum of the glucose and to predict which is patient at more higher risk for PDAC?
We have thought about it, and I think it's important to understand the data from continuous glucose monitoring in these patients, except that you can't use it before diagnosis because you know who are you going to use it in. But I would agree with you that we'll understand more about this if we had continuous glucose monitoring data on these patients. Yeah.
Okay. I mean, I guess maybe to be a little bit out of the box, I was at a meeting in La Jolla where I think some of the others were thinking about early detection of pancreatic cancer, and there's a lot of interest in anything and everything, because the reality is we haven't really moved the needle in the last 20 years in terms of early detection for pancreatic cancer. There is now an opportunity, at least in the United States, for using CGMs over the counter. There's a lot of health curious people, who may do that. There are also people who may be at risk for diabetes because of risk factor, family history, anything. So I think we will start to get some of those data in terms of hypothesizing what we would see, what sort of a signal we could pick up. I really have no idea. But what I would say, just from a omics perspective, is that there's much more data in a 5-day readout from a CGM than there is from a single fasting blood glucose. So I would expect from a mathematical, analytical standpoint, there's more opportunities to detect a signal. Whether or not that signal validates, that's a different can of worms.
Thank you.
We have time for two more quick questions.
I have some questions to ask Professor Zubida. It's a wonderful transitional study, and I am studying on the chronic stress in the pancreatic cancer. And I found that my study had many similarities to your obesity pancreatic cancer. just like the LCN2 is upstream of TYK secretion in the pancreatic, and I do the TYK secretion association to the calcemia and in the pancreatic. So I just wonder, what do you think about the calcemia in the obesity associated cancer?
I'm sorry, talking about hyperglycemia?
Yes.
Yeah, I mean, these mice develop hyperinsulinemia. They cannot handle glucose very well. LCN2 is supposed to help with that, but we haven't yet explored further at the cell level what the link is between the two. But that's a great question.
Just like the LCN2 may be secretion to the muscle cell.
Yes.
Yeah.
So it actually,
Oh, thank you.
It actually, it's another project as to how LCN2 can break down or help regenerate or help with the muscle fibers. So another interesting project and its connection to cachexia, which I know there's some other people that are working on that.
Thanks so much. My question also for Dr. Zobeda. I just wonder, is there any new study planning on the reversing PDAC development with the ferroptosis inhibitors and also GLP-1 receptor antagonists?
Oh, I was hoping somebody, I knew somebody was going to ask me about that. So both of those things that you're talking about are ongoing at the moment, specifically because when you actually delete LCN2 from tumor cells specifically, you actually prevent the ferroptosis inhibition for which LCN2 is associated. So in other words, when LCN2 is high in the tumors, it actually protects against ferroptosis. So the cells cannot go into ferroptosis-induced cell death. And when you do the ferroptosis when you remove LCN2 from the tumor cells, this is not related to obesity, this is not in the adipocytes, just in the tumor cells, and you treat with those ferroptosis inducers, you actually can help them kill cancer cells. So it's very interesting. It's a paper in revision at the moment.
GLP receptor.
Oh, the GLP. Yeah. Pending. Yeah, we'll talk about it more. I don't know the data yet. We're still, the mice are being treated. They're losing weight, but we don't know about the pathology just yet.
Thank you so much.
So I have a question for Dr. Hart. Nobody asked you a question directly.
I thought we were done with questions 2 times ago.
Was it thrombospondin 1 or
go to the break.
thrombospondin 2? You listed thrombospondin 1 as a marker.
Oh, yeah. Question, what about it?
Yeah, isn't it thrombospondin 2?
Oh, it was 1. I think it was 1.
You wrote 1, but I thought it was 2.
I think it's 1.
Okay,
I'll double
look
check.
it up,
I'll fact
yeah.
check. I think that's a yellow to red light biomarker.
So I want to take this opportunity to thank the speakers and the audience, because this was a terrific series of presentations and also a very important series of presentations, because it turns out that the last 6 months before diagnosis is when the pancreatic cancer metastasizes and grows the most. So if you have a window of opportunity to diagnose it early because of some harbinging sign, even a few months can prolong life by a couple of years. So this is very important work, and thank you, everybody.